Thank you for having me. I'm Ada Waks, a breast medical oncologist from Dana-Farber Cancer Institute, and we will go through some updates largely from ESMO and San Antonio at the end of 2024. Lots of exciting data to review. So we'll start with early stage ER-positive breast cancer. We saw at San Antonio this presentation of a sort of sub-analysis of the TAILORx trial. This was a trial that looked at node-negative, hormone receptor-positive, HER2-negative breast cancer. And in this analysis, what they did was they looked specifically at the patients in TAILORx who received chemotherapy. So this was a non-randomized retrospective analysis of outcome according to the type of chemotherapy that these patients received, whether it was anthracycline containing or non-anthracycline containing. This is a super clinically relevant question because we're often left wondering if we've already decided that a patient needs chemo, we're left deciding between a regimen like ACT and TC, and that's often a really tough choice. So as expected in this population where all patients got chemo, if you looked at clinical and pathological factors, the patients who got anthracycline chemotherapy had less favorable disease in every way. They were higher grade, they had bigger tumors, they were younger. That makes sense. What they showed then among those patients who had particularly high recurrence score, so recurrence score greater than or equal to 31, the distant recurrence-free interval was improved if they got the anthracycline in their chemotherapy. So that's what's shown in the right upper panel here. They did better if they got anthracycline in their chemotherapy. That was not the case if you looked at the patients who had somewhat lower recurrence scores of less than 31. The anthracycline versus the TC regimens looked the same there. And that's not what you would have expected because the clinical pathological factors were all worse for the anthracycline receiving patients. So you would have thought that they may have done worse overall. So it really does suggest that the anthracycline may have important benefit in this high recurrence score population. In a subgroup analysis that's shown on the bottom panel there, the data suggested that maybe that important outcome difference didn't apply if you looked just at the stage 1 tumors. So maybe you should be, particularly thinking about anthracycline in the patients who have these extra high recurrence scores, 31 and above, and maybe especially in those patients who have stage 2 tumors. Just to focus in a few other slides, because this is such a common population and question about sort of other data updates and how we apply the TAILORx and RxPONDER data in clinical practice. This is my favorite slide to keep in mind from the TAILORx data. I think the most problematic in clinical decision-making, the most problematic group that we encounter are the premenopausal patients less than or equal to 50 years old who have these intermediate recurrence scores of 16 to 25. We know that if you're premenopausal and you're 26 and above, node negative, we're going to give you chemotherapy. If you're premenopausal and your recurrence score is 15 and below, we're not going to give you chemotherapy in a node negative population. But it's really hard to figure out what to do with those premenopausal patients with these recurrence scores of 16 to 25. And so this is the slide that I always keep in my head when I'm trying to guide that particular population about how much chemotherapy benefit might there be in their particular case. And what you can see here is if you look at these premenopausal patients with recurrence scores 16 to 20, and you stratify them by low versus high clinical risk, the clinical risk definition is on the bottom right of the slide, that, the low clinical risks with those 16 to 20 recurrence scores, they don't seem to have any chemo benefit, maybe 3% clinical benefit in the high clinical risk patients. But if you look in the patients with their current scores of 21 to 25, they're regardless of clinical risk, there's potentially an 8% chemo benefit. This is distant recurrence-free interval, by the way. So these are distant metastases, not DFS events. And in the low clinical risk, it's a bit lower, maybe 6%. In the high clinical risk patients, so these are larger tumors or grade 3 tumors, potentially something like an 11 to 12% distant recurrence-free interval benefit. benefit. So this slide, again, I just like to always keep in my mind as I try to overlay the recurrence score with the clinical risk, essentially tumor size and grade, and guide these patients about how much benefit might chemo have for you. Obviously, some of the chemo benefit or all of the chemo benefit could be a chemoendocrine effect. Maybe we can make it up with Lupron, but these are the numbers that the trial gives us. Just to review what we do with our node-positive early-stage ER-positive breast cancer patients, we have the RxPONDER data. We've seen an updated analysis for these data. These are patients who have 1 to 3 positive lymph nodes and any recurrence score at all from 0, or I should say from 0 up to 25. In the postmenopausal patients shown on the left, absolutely no benefit of chemotherapy for any of these patients at any recurrence score. In the premenopausal patients shown on the right, about a 5% IDFS benefit for any recurrence score. So in this case, it sort of looked like you had the same benefit of chemo regardless, interestingly, regardless of whether your recurrence score was 5 or it was 24. And then these are the DRFS data showing essentially the same thing. Postmenopausal patients, the chemo made no difference. Premenopausal patient, about a 5-year absolute benefit of 3% for distant recurrence-free survival. So for premenopausal patients with 1 to 3 positive lymph nodes and any oncotype up to 25, I tell them in clinic, based on these data, I cannot rule out up to a 3% DRFS benefit of chemo and a 5% IDFS benefit of chemo. Again, we may make up for all or some of that with ovarian suppression, but we're not sure. These are the data that we have. Okay, moving on to trial updates. So we'll keep in this theme of early stage ER-positive disease. This was an update from the WSG ADAPT trial, the hormone receptor positive, HER2 negative cohort of this trial, which is run out of Germany. So first, let me focus on the green patients in the trial schema here. Actually, we've seen these data previously presented, but I think they're clinically important. So these green patients are patients who have low or intermediate risk, early stage ER-positive breast cancer. If they were intermediate risk, meaning they had a recurrence score of 12 to 25, then they had to have Ki-67 suppression with a brief window of endocrine therapy before surgery. So they had to be endocrine therapy responsive or have low risk, a low recurrence score. And in that, the green patients there, they all only received endocrine therapy alone. They did not receive any chemotherapy. And the 5-year distant disease-free survival in that patient population, which was previously reported, was more than 96%. So really good distant disease-free survival for these patients who got no chemotherapy. And it's important to note that this was inclusive of node-positive patients and inclusive of premenopausal patients. So if you're looking for a data set that can give you some reassurance that we potentially don't need to give chemotherapy to all of our premenopausal node-positive patients, as long as you select a low-risk population, this is a good data set to point to. But what was actually reported at the Congress was the red patients here. So these were patients who were high clinical risk. They had a lot of nodal disease, they had a high recurrence score, and they all got chemotherapy. The question that was asked in this population of patients who all got chemotherapy was a randomization to paclitaxel versus nab-paclitaxel. We've previously seen reported the PCR rates for this red group. The PCR rate for nab-paclitaxel was higher, about 21%, compared to the paclitaxel PCR rate. So that was a significant p-value. We saw that previously reported. But the actual primary endpoint of this trial was invasive disease-free survival for the comparison of the two taxanes. I'll just remind you that we have seen a similar trial presented previously, the Gepar-Septo trial, in which nab-paclitaxel improved both PCR and invasive disease-free survival compared to paclitaxel. So this is a somewhat different population, but asking a similar taxane comparison question. In this trial, when they looked at invasive disease-free survival, which is shown on the top here, The trial did not meet its IDFS primary endpoint. Nab-paclitaxel was not superior to paclitaxel. That was the same whether you looked at IDFS, DDFS, or overall survival. It was the same across all subgroups. In terms of toxicity shown on the bottom, there was more grade 3 toxicity with the nab-paclitaxel and especially more hematologic toxicity with the nab-paclitaxel. Neuropathy, another really important taxane side effect, was about the same between the two arms. We also saw an update of the NATALEE trial. This is the adjuvant ribociclib trial. We've seen this presented many times already. So this was an exploratory 4-year landmark analysis of the NATALEE data. The important reasoning behind this 4-year time point is that now all patients are off of their adjuvant ribociclib. I think interesting to note, only 63% of patients completed their intended 3 years of adjuvant ribo, so it's not easy to do a full 3 years of adjuvant CDK4/6 inhibitor. The most common reason for early discontinuation was toxicity, as you would expect. And at this 4-year extended follow-up time point, significant invasive disease-free survival benefit does persist. And what we're seeing is that the absolute benefit of ribo is increasing with longer follow-up. The hazard ratio in favor of the ribo is increasing, looking more favorable with longer follow-up. And this is what we've seen in the adjuvant abemaciclib data as well, that the curves seem to separate more as the follow-up time increases, which is obviously reassuring and promising. We do still have longer follow-up from the adjuvant abema data, of course, but we're seeing the same promising trend with the adjuvant ribo data. They also looked in subgroups and showed IDFS benefit was seen in both node-negative and node-positive patients, both stage 2 and stage 3 patients. The overall survival data are still immature, but there is no OS benefit for adjuvant ribo at this point. Similarly, there's been no OS benefit to date for adjuvant abema. Moving on to metastatic ER-positive breast cancer, we saw the results of the PATINA study. This was a first-line metastatic trial for ER-positive, HER2-negative breast cancer, where the patients were randomized to either get mostly the current standard of endocrine therapy plus palbociclib, or a chemo of the physician's choice, which was mostly capecitabine, a little bit of paclitaxel. These were mostly postmenopausal patients. 40% of patients had liver metastases. And this is the primary result of the trial. So the time to treatment failure was substantially longer in the palbo plus endocrine therapy group. That's the pink curve there. Compared to the chemo groups, really, again, clinically meaningful improvement in this cohort, 17.2 months of time to treatment failure with the CDK4/6 inhibitor versus 6 months with the chemotherapy. That benefit was consistent across all subgroups. It didn't matter if you had liver metastases, symptomatic versus asymptomatic disease. Importantly, it didn't matter if you had endocrine resistant or endocrine sensitive disease. The CDK4/6 inhibitor-based regimen was superior in all of them. So I think this trial just further supports the use of CDK4/6 inhibitor plus endocrine therapy as our initial treatment for these patients. That's true even if you have visceral metastases, even if the disease is symptomatic. Other trials have also shown this. Just to remind you, for example, the Right Choice trial of ribo plus endocrine therapy, which was in premenopausal patients, showed the same thing. And the Young Pearl trial of palbo plus AI versus capecitabine in premenopausal patients also showed the same PFS benefit. So this trial is consistent with those previous trials. We saw the results of the randomized phase 3 EMBER-3 trial, also for metastatic ER-positive disease. This was more or less a second-line endocrine therapy population for metastatic ER-positive disease. About 60% of the population had had prior CDK4/6 inhibitor in the first line. Most of those were palbociclib. And about 35% of the population had an ESR1 mutation. And the design of the trial is shown here. So patients were randomized to either imlunestrant, which is a novel oral SERD, or standard of care endocrine therapy, which could have been fulvestrant or exemestane, but in the end, 90% of those patients got fulvestrant. So this is more or less an imlunestrant-fulvestrant comparison. And then they had this interesting third arm of imlunestrant plus abema. So the first primary endpoint of the trial result is shown on the bottom here, and this primary endpoint was met. So there was an improved progression-free survival with imlunestrant versus the fulvestrant in the ESR1 mutant population specifically, with a median PFS of 5.5 months versus 3.8 months. There was no OS benefit, though those data are immature. The second primary endpoint was not met, which was that if you looked at the same comparison in the overall population and you didn't limit to the ESR1 mutant patients, then there was no PFS benefit in the overall population. So this was sort of limited to the ESR1 mutant population. I would anticipate, based on these results, that imlunestrant as a single agent will become a new treatment option, just like elacestrant is already for hormone receptor positive patients in the second line and beyond if they have an ESR1 mutation. So there was a third primary endpoint, which was also met, which is shown here. So this is the comparison of imlunestrant by itself versus imlunestrant with abemaciclib. And this was evaluated in all patients, not just patients with ESR1 mutation. And this primary endpoint was met. There was improved PFS with imlunestrant plus abema as compared to imlunestrant alone in all of the patients, with 5.5 month versus 9.4 month median PFS. The thing here is that, of course, if you compare imlunestrant versus imlunestrant abema, you're not testing the imlunestrant, you're really testing the abemaciclib here. A fair control arm would have been imlunestrant plus abema versus fulvestrant plus abema, for example. And so this is not a comparison that really helps us understand the efficacy of the imlunestrant specifically. With that, major limitation, I think it's interesting to note that this overall comparison, not only was it positive, but if they broke out subgroups, this benefit was seen regardless of whether patients had seen a prior CDK4/6 inhibitor. So even if you had a prior CDK4/6 inhibitor, the imlunestrant abema was still better, and regardless of ESR1 mutation status. So this was an interesting result, but again, hard to know what to make of it with the control arm not having the CDK4/6 inhibitor. I think in clinical practice, this is just a really useful table to keep in mind, especially because I anticipate that we'll end up with both elacestrant and imlunestrant relatively soon as oral SERD options for our ESR1 mutant patients. So Hal Burstein put this together when he discussed the EMBER-3 abstract, just sort of a Cliff's Notes version of how does the side effect profile of these oral SERDs differ from each other, and how does it differ from an agent we're very familiar with, like fulvestrant. So the highlights here, I think, are the oral SERDs do tend to have more GI side effects. These are generally manageable and low grade, but all of these have a bit more nausea than fulvestrant. The elacestrant and imlunestrant also can have some things like vomiting, constipation, diarrhea. And then the other two oral SERDs, giredestrant and camizestrant, can come with this odd bradycardia side effect, and camizestrant can come with this visual phenomenon called photopsia, which in my experience is noticeable for patients, but not particularly bothersome. But so, there are some differential side effects to keep in mind here. Just a note on an ongoing trial to watch and an ongoing agent to watch for all of us. This trial in the metastatic ER positive population is called TroFuse 010. This is a trial of this novel antibody drug conjugate called sacituzumab tirumotecan, or SAC-TMT. This is an anti-TROP2 antibody drug conjugate with a topoisomerase I inhibitor payload. As a reminder, we've already seen results from the OptiTROP phase 3 randomized controlled trial. That was a phase 3 trial that was in a pretreated metastatic triple-negative population. And in that triple-negative population, SAC-TMT was superior to a treatment of physician's choice for both PFS and overall survival. So this is an agent that has demonstrated activity in triple-negative breast cancer. In this trial, it's being brought into the first-line chemotherapy hormone receptor positive population. And these patients are being randomized between the SAC-TMT with pembrolizumab, and a treatment of physician's choice arm. I think a limitation of this trial is that the treatment of physician's choice arm does not have TDXD as a first-line chemotherapy option here. We'll talk about DB06 a little bit later, but there are some patients at this point where we would use TDXD as a first-line chemo option probably, and that wouldn't be allowed in the control population of this trial. More on ADCs in hormone receptor positive breast cancer. So we saw in a special ESMO virtual plenary the final overall survival data from TROPION-Breast01. So this was the randomized phase 3 trial that compared the ADC Dato-DXd to the treatment of physician's choice chemo. So Dato-DXd is a TROP2 targeted ADC with a DXd payload, same payload as TDXd. We already have seen the PFS co-primary endpoint of this trial presented, and it met its PFS co-primary endpoint with a median PFS of 6.9 versus 4.5 months. Based on that PFS advantage, this agent has regulatory approval in the United States for ER-positive pretreated metastatic breast cancer. However, what we saw in this presentation is that the overall survival co-primary endpoint of this trial was not met. There was no overall survival advantage of Dato-DXd, although there was the PFS advantage. There's been a lot of discussion about whether this is because of crossover and receipt of subsequent ADCs by the patients in the control arm. They presented those data and showed us that 24% of patients in the control arm got a subsequent antibody drug conjugate versus 12% in the Dato arm. Is that enough to explain why no OS benefit was seen here? I think we don't know. For safety with this agent, there was significantly less neutropenia in the Dato arm than in the standard chemotherapy arm. I think in clinic, two really important side effects to keep in mind when we use this agent are that this agent, the Dato-DXd, it causes stomatitis and it causes dry eye. So I use prophylactic dexamethasone mouthwash and lubricating eye drops for all patients when I administer this agent. And finally, the updates from DESTINY-Breast06. So this is the phase 3 randomized controlled trial that compared TDXD versus treatment of physician's choice, which could either be capecitabine or a taxane. The majority of patients were getting capecitabine, though, in the initial chemotherapy setting for hormone receptor positive breast cancer that was either HER2 low or ultra low. We previously saw the PFS primary endpoint of this trial reported. The trial showed a benefit for TDXD in terms of median PFS in the first-line setting, 13.2 months for TDXD versus 8 months for the treatment of physician's choice. There's no overall survival difference seen at this time, although these data are immature. I think it's important to point out that TDXD, we know, has both a PFS and an overall survival benefit in the second line setting for hormone receptor positive metastatic population. But this first line trial to date has not shown an overall survival difference. So the additional analyses that we saw presented at San Antonio were basically showing us that the PFS difference that favors TDXD is seen across subgroups, regardless of your disease burden, regardless of your time to progression on prior endocrine therapy. TDXD had a more favorable PFS compared to the capecitabine or the taxane. We also saw the presentation of the PFS2 data, which is shown on the bottom here. No big surprise, TDXD was also better than treatment of physician's choice in terms of PFS2. But the thing is that, as they showed in this presentation, only 8% of patients on the TPC arm went on to receive an ADC as their immediate next therapy. And so I really don't think that these PFS2 data help us to decide who should get TDXD in the first versus second line setting, because the TPC patients in this trial, by and large, were not getting something like TDXD in the second line setting. So we don't know what this PFS2 result would have looked like if actually patients had crossed over to TDXD in the second line. We also saw some additional analysis of the HER2 low and ultra low status assessment in the DESTINY-Breast06 trial. Just to remind you that in this trial, a central test confirming either HER2 low or ultra low status was required for enrollment, but all patients had a clinical test result available as well. They found 70% overall agreement between central versus local testing for HER2 low status. And then of the patients who had locally assessed HER2 IHC 0, so remember, HER2 ultra low was not a label that existed when they were beginning to enroll this trial. So no patient would have had a null versus ultra low result read out. They were just all HER2 IHC 0. What they found was that of those locally assessed to have HER2 IHC 0, 64% were then either HER2 low or ultra low on central review, and therefore they were eligible and went into the trial. I think for us in clinical practice, what this underscores is the importance of going back to re-review patients' quote unquote IHC 0 results in clinical practice if we're trying to find some patients who actually are potentially candidates for T-DXd. And then one final thing about these DESTINY-Breast06 results that they showed at ESMO is that if you look at the bottom of this forest plot, they looked at the hazard ratio and how it favored T-DXd across the ultra low, the IHC1, and the IHC2 plus patients here. And you can see in this bottom line that it did look like if you had IHC2 plus disease here, so sort of the higher level of the HER2 ultra low, or of the HER2 low, that maybe you did have more benefit from T-DXd. This is not what DESTINY-Breast04 had shown. DESTINY-Breast04 had looked like, doesn't matter if you're IHC1 plus or 2 plus, you get basically the same median PFS out of T-DXd, and DESTINY-Breast06 looked a little bit different in that regard. It looked like maybe your PFS is longer if you had 2 plus as opposed to 1 plus or lower. That's not to say that you shouldn't use this drug in a HER2 low or ultra low patient. It's still better than treatment of physician's choice. But in clinical practice, I think it brings up the interesting possibility that maybe if your patient is a little higher on the HER2 low expression scale, their PFS might be longer. Again, I think that's a very open question. It conflicts with previous data. This is an interesting agent that's in development for all sorts of breast cancer called Patritumab deruxtecan. This is a HER3-targeted ADC with a DXd payload. These are the results of the phase 2 Icarus Breast01 study. This was pretreated metastatic hormone receptor positive breast cancer. All of the patients in a single-arm design got HER3 DXd or Patritumab deruxtecan. And in this chemo pretreated, CDK4/6 inhibitor pretreated population, you can see in the waterfall plot on the left here, there were very nice clinical responses. The overall response rate was 54%. Median PFS was 9.4 months. So, I think a really promising agent. We don't have any phase 3 data from this agent yet, but very nice phase 2 results here. And importantly, this is a HER3 targeted agent. But when the authors looked at whether you were more likely to respond or to benefit based on HER3 expression level on your tumor, there was absolutely no correlation. So you seemed to benefit regardless of HER3 expression level. This is the safety associated with the HER3 DXd or Patritumab deruxtecan, generally a well-tolerated agent. It can cause ILD like pretty much all DXd payload agents, but you can see only a 7% rate of ILD, all of which were grade 1, and otherwise the grade 3 toxicities were pretty uncommon. Okay, moving on to triple-negative breast cancer. So we saw, let's start with early stage disease. We saw updates from the Keynote 522 trial. This is the practice-changing trial adding pembrolizumab to a chemo backbone in stage 2 and 3 triple-negative breast cancer. Basically, with every update, we see further and further benefit from the pembrolizumab. That's the short version here. So with updated event-free survival, we continue to see fewer EFS events with Pembro, 9% absolute difference to be exact. We now see a statistically significant overall survival benefit for the addition of Pembro, 5% fewer overall survival events with the Pembro. I think this confirms that we should be using this agent, pembrolizumab, widely in stage 2 to 3 triple-negative breast cancer, essentially universally. It's associated with a clinically meaningful and statistically significant EFS and OS benefit. But I think important to keep in mind, 13% of patients on the pembro arm of this trial had a grade 3 to 5 immune-related AE. So there's real toxicity of this agent as well that we have to keep in mind. We also saw some exploratory subgroups presented, for example, looking at the benefits of pembro in patients with positive nodes versus negative nodes, patients with T2 and 0 disease, so sort of the anatomically lowest risk patients who were eligible for the trial. I think the take-home message of all of these exploratory subgroup analyses was that the relative benefit of pembro is maintained even in lower risk subgroups by clinical criteria. And so, there's not an anatomic disease burden within this trial where there wasn't benefit of the immunotherapy agent. That being said, as expected, the absolute benefits are smaller in a lower anatomic risk population. So in the node positive population for overall survival, there was a 7% absolute benefit in favor of pembro. In the node negative population, a 3% absolute benefit in favor of chemo, in favor of pembro, though the hazard ratios were the same. And then again, some exploratory biomarker analyses from Keynote 522. I won't go into great depth here, except to say that what they showed is that the benefit of the pembro was consistent across all of the different subgroups that they could pick out. They examined tumor mutational burden, inflammatory gene expression signatures, triple-negative molecular subtypes, and across all of those subgroups, it looked like everyone was benefiting from the immunotherapy. The results of the NSABP B59 trial were also presented. This was essentially the Keynote 522 trial, but with atezolizumab instead of pembrolizumab. So again, stage 2 to 3 triple-negative population. Everybody got a chemo backbone, randomized to atezo in the neoadjuvant and adjuvant setting or placebo. In terms of PCR, shown on the bottom left here, there was a statistically significant, although somewhat modest difference, but statistically significant difference for PCR with the addition of atezolizumab. But the primary endpoint of this trial appropriately was EFS, and there was no statistically significant difference for EFS, which is shown on the right here. There was also no overall survival benefit. And so the conclusion here is that atezolizumab does not provide long-term benefit in early-stage triple-negative breast cancer. That's very distinct from the data I just showed you with pembrolizumab, which shows benefit across the board. We saw a 10-year update of the OlympiA trial. This is the trial looking at adjuvant olaparib in high-risk HER2-negative early-stage breast cancer. We already know from previous reports of this trial and publication that there is a significant IDFS, DDFS, and OS benefit for all the patients who enrolled in this trial, but this was a further pre-planned 10-year update. Basically, what it showed is that the IDFS, DDFS, and OS benefits persist at this 10-year time point, and the absolute benefits actually increased with longer follow-up across all of these endpoints. I think another really important outcome from this very long-term follow-up time point is that we continue to see absolutely no safety signal for MDS or AML in the olaparib arm. This is a big worry that we have when we, or had historically, when we prescribe a PARP inhibitor for a curative intent patient, but we have seen no concerns about this in this trial cohort. The rate of MDS or AML was 0.4% in the olaparib group, actually numerically slightly lower than the placebo group, where it was 0.7%. Also, at this very long update, we're able to see again that there are numerically lower rates of new primary breast cancers, new primary ovarian cancers, and new primary pancreas cancers in the olaparib group, which suggests that there's potentially a preventive benefit of the PARP inhibitor here as well. So again, in moving on to metastatic triple-negative breast cancer, there was an update of the OptiTrope Breast-01 study. So this is the study of the sac-TMT TROP2 ADC that has previously resulted for pretreated metastatic triple-negative breast cancer. And again, as we talked about earlier, we already know that there's a significant PFS benefit of the sac-TMT over the treatment of physician's choice in this patient population. What this subgroup analysis was asking is whether if you looked at patients who had received a prior immune checkpoint inhibitor versus those who hadn't, did they still seem to benefit from the sac-TMT? I think that's a clinically relevant question because we don't know necessarily how many of these novel agents work after immunotherapy in metastatic triple-negative disease. And what they showed in this subgroup analysis is that the sac-TMT benefit persisted regardless of prior immune checkpoint inhibitor receipt. And so I'll close out in the final 2 slides with a metastatic HER2-positive breast cancer. So we saw results of the DESTINY-Breast12 clinical trial looking at the activity of T-DXd in patients either with or without brain metastases. This has been a super important open question clinically because we know many of our metastatic HER2-positive breast cancer patients have brain metastases, and we really haven't had good data about T-DXd in that particular population because they were largely excluded from the earlier Destiny breast trials. So in this trial, they enrolled patients who either did or did not have brain metastases and basically followed them for outcomes with T-DXd. So it was a single-arm treatment trial. The enrolled brain metastasis population had a median of 1 prior regimen for metastatic breast cancer, so it's more or less a second-line trial. The median PFS with T-DXd for the brain met population was 17.3 months, and the 12-month landmark PFS was totally consistent across patients who had either stable or active brain metastases. You can see here the CNS progression-free survival was essentially the same as the overall progression-free survival. Again, it didn't matter if you had stable or active brain metastases. The CNS overall response rate was 72%, very good overall response rate, again, essentially the same as the response rate in the body. So this trial really confirms the activity of T-DXd. It shows that it works pretty much the same intracranially and extracranially for patients with both stable and active brain metastases. And then lastly, the PATINA trial, which was presented at San Antonio. This is, I think, an immediately practice-changing trial for our patients with ER-positive and HER2-positive metastatic breast cancer. So this was a trial that took those patients who were both ER and HER2-positive. They had completed their induction taxane chemotherapy in the first line for metastatic disease, and then were randomized to either get the standard, which is trastuzumab and pertuzumab with endocrine therapy, or to get that standard HP plus endocrine therapy with palbociclib. The primary endpoint of this trial was PFS, and those results are shown here. The palbociclib arm did substantially better than the non-palbociclib arm with a median PFS of 44 months versus 29 months, so a 15-month difference in median PFS with the addition of CDK4/6 inhibitor here. And again, I think this sort of right away changes our standard practice for first-line treatment of ER-positive, HER2-positive disease.